and appropriate care when needed, regardless of your background or personal circumstances. So, as aspiring medics or dentists, we should know that the NHS was founded on the principle that healthcare should be accessible to everyone, no matter their finances. Everyone should essentially be able to receive the same level of care. However, through research, we see that this is not the case. This topic is vital because health inequalities are widening across the UK. The Public Health England 2021 reported that people living in the most deprived areas of the UK live 8 to 10 years less than those that live in the least deprived areas. So, what are our aims and objectives? In today's presentation, we aim to explain how different socioeconomic factors influence access to healthcare in the UK. We're going to share an example and discuss potential solutions.
Key socioeconomic barriers include income and resources, time and opportunity costs, education and health literacy, stage of illness at presentation, and outcomes gap, and a concept known as postcode lottery. Income and resources. Even though the NHS is free at the point of use, wealth still matters. Wealthier people can afford healthier lifestyles, private healthcare, and additional resources. For example, specialist visits. Poorer people often live in environments with more health risks, like pollution, stress, and unsafe work. Time and opportunity costs. For someone in a low paid or insecure job, missing work for a doctor's appointment can mean lost wages. Travel costs and childcare are extra barriers. This reduces uptake of preventive care, like screenings and vaccinations. Education and health literacy. People with lower education may struggle to understand medical information or navigate the NHS system. Wealthier patients are often more confident pushing for referrals or specialist care. Stage of illness at presentation. Poor groups often delay seeking help until illness is severe. This leads to higher need for emergency care and worse long-term outcomes. Quality and outcomes gap. NHS care quantity is actually pro-poor, which means lower socioeconomic status groups use more NHS care overall. But the quality is pro-rich. Wealthier people get faster referrals, earlier treatments, better experiences, and better outcomes. Geographical inequality. Access varies depending where you live. For example, fewer GPs in deprived areas, longer hospital waiting times in certain regions, and other factors. Even though funding tries to adjust for need, it doesn't always match reality.
Evidence and impacts. Income and deprivation. People in the most deprived 20% of areas have twice as many emergency hospital admissions due to infectious diseases as, as the less deprived. This inequality highlights how poverty directly influences health outcomes. Individuals on lower incomes are more likely to delay seeking care from their GPs, often due to difficulties taking time off work, transport barriers, or a lack of access of available services. As a result, they tend to rely on emergency departments once conditions have worsened. Geography. Ru- Rural and deprived areas have fewer GPs per thousand people and longer wait times. In some remote areas, public transport options are limited or unreliable, making it harder for patients without private vehicles to attend appointments. These challenges result in longer waiting lists, reduced continuity of care, and missed appointments, which can worsen chronic conditions and delay early diagnosis of serious illnesses. Education and health literacy. Lower education levels reduce understanding of how to access or navigate NHS services. For example, how to register with a GP, book screenings, or understand referral pathways. This lower health literacy can cause confusion and anxiety about seeking care, leading to fewer preventative visits, poorer adherence to medical advice, and higher long-term illness rates. In contrast, those with higher education levels are more proactive about maintaining their health through regular checkups and screenings. Ethnicity and cultural barriers. Some ethnic minority and migrant groups are less likely to use mental health or screening services due to stigma. This is often due to language barriers, mistrust of institutions, or fear of stigma within communities. This results in underdiagnosis of conditions such as depression, cancer, and diabetes, and often leads to poorer overall health outcomes. A case study: Blackpool is one of the most deprived areas in the UK, with male life expectancy around 73 years old, 6 years below the national average. Residents rely more on A&E and have higher emergency admission due to limited resources and financial barriers. This shows the importance of the point of poverty and income deprivation. This case also shows that lower health literacy contributes to delayed GP visits and misunderstandings of how to navigate NHS services, as residents face limited access to primary care with approximately 2,450 patients per full-time GP in deprived areas as compared to fewer patients per GP in wealthier regions.
So, what are the solutions? So, first off, increasing NHS funding in deprived areas is actually proven to make a difference. When more money is targeted at areas with the worst health outcomes, mortality from preventable diseases actually goes down. So, it's essentially showing us that when resources are distributed more fairly, the gap between rich and poor communities starts to close. Next would be health literacy. So this is a massive one. If people don't know when or how to access services or what's covered, that's already a big barrier. So things like teaching basic health knowledge in schools, workplaces, and local centers could really help people take control of their health. And to ensure that this isn't neglected, the NHS recommends the government collect robust data to track these improvements. Now, digital exclusion. This became really obvious during COVID when GP appointments moved online. For people without internet access or who aren't confident using tech, getting care became a lot harder. So NHS England's now made it a priority to fix this and make sure there's always a non-digital option. And finally, community level solutions. This one's more about connecting people. When communities are more engaged, like through local centers, parks, community boards, health awareness will naturally spread. And it also helps reduce isolation, which is a big factor, especially in the elderly, linked to poorer health outcomes. So to wrap up, all these ideas really link back to one of the three core values the NHS was built upon: care based on need and not ability to pay. Unfortunately, right now, socioeconomic gaps make it harder for the NHS to live up to that. So, if we can reduce those inequalities, we're actually protecting a major value the NHS was founded on. Thank you.
Thank you so much for listening. Please fill out the feedback form so then we can improve in our next presentation. Thank you so much.